Good afternoon. It is my pleasure to introduce Dr. Thomas Bleck, this year's Lifetime Achievement Award winner. As we learned this morning, Dr. Bleck is a professor of neurological sciences, neurosurgery, internal medicine, and anesthesia at Rush University Medical Center, where he is a neurointensivist and the director of clinical neurophysiology. From 2009 to 2015, he was the Associate Chief Medical Officer for Critical Care at Rush and recently served as the Interim Neurology Residency Program Director. He has served as a director of the American Board of Clinical Neurophysiology. He is a member of the Writing Committee of the American Board of Psychiatry and Neurology and was a member of the American Board of Internal Medicine Subspecialty Exam Committee for Critical Care Medicine from 2011 to 2017. And in 2016, he was elected to a fellowship in the American Epilepsy Society. In 2017, he was elected to the Board of Directors of the American Neurological Association, and he is also a fellow of several other medical organizations, including the Infectious Diseases Society of America and the Royal College of Medicine, and he is a Master of Critical Care Medicine. And I counted, he has been a member of at least 39 professional societies during his career. He also served, as you heard earlier today, as the first neurologist on the Society of Critical Care Medicine Council from 2000 to 2012. These are Dr. Bleck's accolades and accomplishments, but on a more personal note, I'd like to say I believe that each one of us can look back in one's lifetime and find someone who has been inspirational to us as a role model, to motivate us and to support us in our career and endeavors to help patients and to make a difference for others. Dr. Bleck has been that person for me as my Neurocritical Care Fellowship Director at the University of Virginia and all these many years after. And I know he has also been this for so many others wherever he goes. Dr. Bleck is thoughtful and insightful and above all warm and supportive. But he can be pointed and direct when needed. He cuts through the fog and gives clarity with his advice and his comments. Neuroscience critical care, a newly acknowledged branch of critical care, required a thought leader, a strong leader, intuitive, level-headed, super smart, friendly, congenial, and well-respected nationally and internationally to help establish this field as one that could contribute to best patient care. This leader, Dr. Bleck, served as the first and founding president of the Neurocritical Care Society and helped shepherd this effort, and for that, we and our patients and their families are extremely grateful. Please join me in welcoming Dr. Bleck, this year's Lifetime Achievement Award winner, as he presents How Critical Illness Affects the Brain and Vice Versa.
Well, thank you, Cheryl. That was a nice talk about somebody. So I hear the usual disclosure slides, but none of them really apply much for this. So this is Roger Bone. Roger was the chief of medicine at Rush starting in about 1984. And he was also someone who was very smart and very blunt. And one day he called me into his office and said, "You know, Bleck, by constitution you're an intensivist, and you should just admit this and get on with your life." So I would say that was the single most pointed and useful bit of advice I ever got in a professional mode. And Roger unfortunately passed away at age 56 of a renal cell carcinoma, but almost up until the day he died, he was still hard at work. He was the first recipient of the Lifetime Achievement Award. There have been, of course, many others. Here's the list through Pat Kohanek last year. Just amazing people, and I'm very proud to be in this company. So back in the late 80s, we did a 2-year study in the medical ICU at Rush trying to uncover the neurologic complications that occurred in the course of non-neurologic critical illnesses. And from that, we determined that the most common problem to develop was an encephalopathy. It was not well recognized that sepsis itself could cause an encephalopathy. Seizures were second most common. The development of hypoxic ischemic encephalopathy or strokes in the course of a critical illness were the next most common. Turning it another way, sepsis was the most common cause of encephalopathy, and this was after we tried to assign people as much as we could to either hepatic or renal or these other causes that you see. So we were surprised to determine that septic encephalopathy was in fact so common in the MICU population. Looked at from another direction, the neurologic complications associated with sepsis, in addition to encephalopathy, were similar to the ones that we've seen in other patients. Well, a lot of other things can happen to the septic patient aside from encephalopathy. They can have spinal cord dysfunction. We've always attributed this to hypotension, but in fact there may be other mechanisms that are just being determined now. There are a number of neuromuscular complications of sepsis. We were not looking for these in our study, but these are things that can contribute to the long-term difficulties that septic patients encounter during their rehabilitation. Many mechanisms had been proposed for this at that time, so in the 1980s, people were very interested in trying to blame the liver for just about everything. Serotonin metabolism remains something that's important to think about. When you don't know what's going on, you can always blame cytokines. There are still people interested in these endogenous benzodiazepine-like compounds. I think it's clear that there has to be a purpose for the benzodiazepine binding site on the GABA receptor, but no one has really figured out what the endogenous ligand is. We used to think it was a neurosteroid. It's now clear that there's another binding site that explains most neurosteroid activity. So we're still waiting to see what this is, but there is something that can be antagonized by things like flumazenil. Intracranial pressure does go up early in the course of sepsis. The mechanism for this remains to be determined. A lot of interferons will have CNS effects. And back then, there was the notion that occasionally there would be actual infection of the brain, something I'll return to at the end of the talk. The blood-brain barrier can be damaged by systemic inflammatory mediators, and some of the cytokines are responsible for the thermogenic behaviors we're used to seeing in terms of people becoming febrile in the setting of sepsis. Interferons themselves can also affect neuronal activity directly. Of course, the septic encephalopathic patient has many other possible reasons to have encephalopathy aside from sepsis itself. I won't read you this laundry list, but you'll notice it's quite extensive. Brian Young did a study that I think is often overlooked but is quite important. This was done in the 1990s. Here, the definition of sepsis still often included bacteremia. So Young and his colleagues did EEGs, just a regular 20-minute routine EEG, the day after any patient in the medical surgical ICU at Western Ontario was found to be bacteremic. And what they found here on the abscissa, you've got the EEG categories. The open boxes were representing patients who were not encephalopathic. The ones that are speckled were moderately encephalopathic, and the solid ones were severely encephalopathic. So if the EEG was normal, the patients were all normal, and there was almost no mortality to speak of. However, if they had modest slowing, most of them were moderately encephalopathic, but the mortality here was over 40%. If they had delta frequency slowing, some were moderately and some were severely encephalopathic, the mortality went up a little bit. Triphasic waves, which are usually considered a marker of metabolic encephalopathy, not specifically hepatic, raised the mortality up to a little over 50%. And if there were any suppressions in the EEG, so periods of flattening, the mortality rose to about 70%. This has not been repeated as far as I can tell, but we do know a lot more now about what the EEG looks like in encephalopathic septic patients. I think it's important to keep this in mind. At the time, it was actually the strongest predictor of mortality. We're starting to come to understanding a little bit more about mechanism here. This actually from the laboratory of Dr. Vincent and his colleagues shows that in this case of experimental peritonitis in sheep, sepsis was associated with an alteration in the cerebral microcirculation. So here we have capillary density viewed through a cranial window, and in the septic animals as opposed to the sham animals, the capillary density is decreasing. The proportion of small perfused vessels visible is also decreasing. At the same time, the brain tissue oxygen, which starts out fairly normal for the first several hours, then begins to decline. And this is not explained only by the drop in blood pressure. Now, when you see a drop in tissue oxygen and a change in blood flow, you have to think, what's the cart and what's the horse? but it's clear from looking at lactate pyruvate ratios in the cortex that this tissue is becoming ischemic even when one tries to maintain the blood pressure, just in the consequence of sepsis. So these authors tried to put together the sort of diagram that drives everyone crazy when they're studying for exams in order to try and piece all of these things together. So endothelial activation is a prominent part of sepsis that's releasing inflammatory mediators that will affect both oxidative stress in the brain, but also affect the production of neurotransmitters. The endothelial activation is associated with blood-brain barrier breakdown, which allows neurotoxic substances to cross the blood-brain barrier, and again is going to affect both neurotransmitter function and cellular function directly. On this side, we have the more typical hemodynamic disorders, all of which end up perhaps producing encephalopathy as individual things, and there's some making it very likely that the patient would be encephalopathic. Now, every field of medicine has to have laws. Those of you who've read The House of God may remember the 13th and ultimate law, the delivery of good medical care is to do as much nothing as possible. I think we heard that in the presidential lecture this morning. But there are laws of neurocritical care. It's important to remember at the cellular level, almost all of the disparate conditions we deal with that affect the brain share just a few mechanisms that are important. Well, the primary goal of neurocritical care is to keep the intracellular free calcium concentration appropriate. Now, the question is, A, we can't measure it at the bedside, so how would we know what's appropriate? But it's important to remember that an increase in extracellular free calcium triggers a number of enzymatic systems that will damage both neurons and astrocytes and can result in cell death. These systems normally are there to promote learning and memory, but their overactivation can cause seizures, cell damage, and death. The second goal is to prevent or mitigate damage from oxygen-derived free radicals, and a third is to modulate the activity of the immune system as it deals with damage to the CNS. And this is the one that is, I think, going to emerge most in the next 10 years. If we use status epilepticus as an example, when seizures start, or truly also when ischemia starts or when trauma occurs, you have a number of things that are occurring within milliseconds to seconds. Within seconds to minutes, though, we have a number of very well recognized things that are going to be affecting the ability of the brain to control its intracellular free calcium levels. We're going to lose GABAergic inhibition, but have excitatory amino acid receptor systems get elevated. This is going to allow a lot of free calcium to enter the cell. Within minutes, we'll start to see changes in neuropeptides, and even if the ictus itself passes, there are longer-term genetic and epigenetic changes that change the brain forever. So Sutter and colleagues have tried to give us a review of these systemic complications, and although this diagram is a little hard to see, we can clone in on it a little bit here. Looking just at the cerebral side, once the cellular pumps start to fail, then the cell stops extruding the extracellular free calcium that's already present. You also get a failure of potassium-sodium exchange. Both of these result in further depolarization, the release of glutamate into the extracellular space. That's going to trigger the processes I've just been discussing in the postsynaptic neurons, both from the calcium side and from the hypersodium side here. That glutamate will continue to activate cells, but will also begin to spread throughout the extracellular space in the brain to areas very distant from the original site of injury. Nitric oxide can also contribute to it. Now, nitric oxide is a two-edged sword. Sometimes you need its vasodilation, and sometimes it results in free radical damage. These systems also feed back to the nucleus and actually change the cell forever. Now, if we look at a more focal thing like a stroke, going from the most ischemic areas to the ones that are least involved, we have these same things happening, but they're spread out geographically. The summary of both some of our inflammatory mediators plus the production of peroxynitrite, which goes on to cause DNA damage, and also lipid peroxidation, which will punch holes in the cell membrane and make it hard to maintain iodic gradients, along with the more typical things we're used to looking at in critical care, will result in cellular damage and apoptosis. One of the things that's become of greater importance in our studies more recently is to look at the difference in the temporal changes in how macrophages, and in particular microglia, work. Now, brain microglia are at least half derived from peripheral macrophages, but there are also cell lineages within the nervous system that support the production of more microglia. Early on, they are inflammatory. Later, they can become beneficial. Now, this became one of Roger Bone's great interests as his career progressed. He initially thought that overinflammation was responsible for the damage associated with sepsis, and that damping it down with steroids might be helpful. And we're still trying to deal with what the steroids do in sepsis. I won't try to settle that today. But later on, he got concerned about to what extent the septic state became one of immunosuppression, allowing secondary infections. And this is happening in the brain as well as elsewhere in the body. Now, when you hear ion channels, you typically think that this is something that's going to just affect neurons. But in fact, inflammation not only affects neurons, but affects ion channels in the microglia themselves. And it is in fact possible that we can modulate the effects on the microglia of changes in these ion channels with drugs. So they have this constitutive production in the microglia, and they have identified this as a promising therapeutic target in this group from pharmacology at UC Davis. So the neurotoxic effects of reactive astrocytes are becoming recognized as well, and those activated microglia can actually convert the astrocytes into cells that are damaging to the surrounding cells. And in fact, it's becoming, I think, more common in basic neuroscience now to think that neuroinflammation is really a misnomer, that we have to be at least as concerned with the supporting cells, the macrophage monocyte systems, and also the astrocytes in terms of their inflammatory potential. And if we want to move ahead, in fact, we have to make those microglia great again. So this is Kevin Tracy, who will be talking to you on Tuesday morning. I'm not going to try to steal his thunder, but he is responsible for a lot of the work of understanding how the brain is affecting the immune system and the rest of the body. Kevin is a neurosurgeon who spends most of his days in the lab, but still goes in the operating room about once a week. And he uncovered what he termed the inflammatory reflex. Now, that gets us into the pathogen-associated molecular patterns that exist to trigger immune cells, but also danger-associated ones. So the pattern-associated ones are typically coming from exogenous organisms, and the danger-associated ones are from damaging to structures like mitochondria. They still converge on our immune cells and can produce immunologic damage. Well, when you hear about a reflex, you think about tapping on a tendon and watching a muscle contract. But some of the cells of the immune system also trigger reflexes, and in particular, neurons that bear this particular sodium channel can actually feed back into the immune system and decrease inflammatory mediators. This will result to some degree of tissue protection as long as the initial injury can be managed. In addition, cytokines and the PAMPs and DAMPs working via vagus reflexes through the brainstem release acetylcholine that affects the function of splenic macrophages and a number of other mediators within the immune system. We'll get back to this in a second. In addition, salmonella in particular, but also these danger signals via the vagus through a reflex arc that has yet to really become well understood, ends up releasing norepinephrine and downregulating macrophage function as well. So you might have wondered, well, why are there nerves going out to these places? Well, we know that nerves affect heart rate and contractility, but they also affect immune system function, particularly in the spleen, where, in this case, acetylcholine, acting at a cholinergic receptor on a macrophage, is decreasing the production of TNF, IL-1, and the high mobility. There's more, of course, going on than that. In addition to the acetylcholine, pain fibers that release substance P in both directions can increase TNF. That's not a surprise that there's inflammation going up there. But the sympathetics, it can at least indirectly either up or down regulate TNF depending on whatever else is going on in the system. In addition, there are a number of circulating mediators released by the brain that will have systemic effects. As we try to put all these things together, you can see that there's not one single neuromediator that's going to control immune function, and this is an oversimplified version, and at this point it's already becoming somewhat difficult to keep all these pathways in one's mind. There are some more easily measurable parts of it. We can look in humans at heart rate variability, and that actually is a marker for this cholinergic anti-inflammatory pathway. What Kevin, I think, will spend some time talking about is that the vagus nerve stimulator that we've used for the management of epilepsy for a long time also has direct effects on the immune system. This is perhaps one of the mechanisms that needs to be studied into why vagus nerve stimulation seems to decrease sudden death in epilepsy. The catecholinergic system can actually open the blood, or in this case the blood CSF barrier, and allow T cells to enter the central nervous system. This may help explain a number of situations in which inflammatory conditions at various levels of the cord and probably at the brain can be understood better mechanistically. Interrupting the danger-associated molecular signals, it turns out to be, at least in experimental models, a useful strategy for decreasing the damage produced in pneumococcal meningitis. As you may know, our current antibiotics lyse the pneumococci so quickly that you get a huge outpouring of an immune response that seems to be responsible for some of the cranial nerve damage that's associated with the treatment of meningitis. So even though survival is improved by these drugs, we are now currently giving steroids to try to dampen down the overexuberant immune response. It may be that we can focus more specifically and not give such systemic immunosuppression at a time when we're still trying to clear infections. The drug treatments that were often used in the intensive care unit also affect both systemic inflammation and its central nervous system mediation. So I think as time goes on, we're going to have to pay more attention to the effects of what we think of as fairly simple sedative agents and how they might be affecting our patient's ability to respond to infection. There are also inflammatory mediators in the setting of lung injury, which I'm going to return to in just a moment, that may have a direct effect on the brain. We know clinically that this is important. We don't know mechanistically what the pathways that are involved would be. So heart-brain coupling in sepsis, in addition to heart rate itself, looking at the variability of the heart rate and comparing it with the EEG suggests that this change in heart rate is also a marker for the development of encephalopathy. Cliff Deutschmann, who's very famous within our society, has also shown now that changes in orexin activity are associated with altered vital signs, and in particular, the loss of orexin results eventually in hypotension. And he's now studying whether replacing that loss of orexin can improve survival in experimental sepsis. Everyone's familiar with the output of the hypothalamic pituitary adrenal axis, but I think now you've seen that there is, in fact, more than just simply releasing cortisol that's of importance in the way that the body responds both to critical illness and surgery. Now, I have to say that in the past I had been somewhat skeptical of the notion that music is going to help improve survival and to improve the outcome of our patients when they're comatose. But there may in fact be more mechanistically going on here than I had originally thought. And in fact, we may be able to dampen down some of the hypermetabolism that's going on in the septic patient via just playing music. I know it's a little hard to accept, but I think we will see this emerge as an important ancillary treatment in our patients. The acetylcholine receptor doesn't just cause your muscles to contract or allow glands to secrete. And if you agonize the alpha-7 nicotinic acetylcholine receptor, it can actually improve survival in sepsis in mice. And so this is just looking at the survival when you antagonize it versus have, this is the vehicle here. This is the vehicle side. So a high enough dose of this will result in improved survival. To summarize what we've discussed so far, I think you can see that we've already done a lot with the inflammatory system. I haven't touched as much on free radicals and lipid peroxidation, but they remain important. I spent the first 10 years I was in Virginia trying to work on drugs that would affect this. I have to say we've not been particularly successful in that quest, but it remains important. Excitotoxicity, I mentioned already. Mitochondrial dysfunction shares some of the characteristics of these. Things that disrupt the blood-brain barrier can produce cerebral edema and also worsen the consequences of hypoxia and ischemia and the cell death pathways we've touched on briefly. So how should we consider what goes on to these septic patients? I think this term, acute brain failure, is probably the most useful one, and sort of let's discourage use of other kinds of terminology now. Having said that, acute brain failure is not a single entity any more than acute lung injury or acute renal failure have a single cause and a single prognosis. When we talk about patients being delirium, if we use the DSM-5 definitions, we might say that people are on a spectrum from normal to delirious, and that it's this sort of uniphasic thing. You're somewhere along this, and we might think that some drug treatment might help us move from there to here, or that some of the things we're doing to the patients drive them from normal toward delirious. But we need to be a little bit more inclusive, otherwise we come up with studies like this that you may have seen in the last few years. If we think that haloperidol, for example, is a safer way to try and prevent or manage delirium, we have these two studies now showing that giving prophylactic haloperidol basically just decreases the amount of PRN haloperidol you give, that it doesn't have any sort of protective mechanistic effect. So I think we need to take a step back and think a little bit more about how the brain is functioning. So we could have an arousal axis that is unrelated to content. So this is going to go from coma at one end to being hypervigilant at the other end. So that's normal, decreased arousal, increased arousal. We can have a mood dimension that we go from being depressed toward manic. We have a content dimension where the patient may be arousable but has no content in a vegetative state through normal content. I don't know what hypernormal content would be, but I'd like to find out. And then there's an hallucinatory dimension, psychotic at one end, not clear what the other side of this would be. So this is where we might expect that dopamine blockers like haloperidol are going to work unless we give them in such doses that we try to actually blunt arousal. We have better drugs for blunting arousal. Sleep, by the way, doesn't really fit on this. Sleep is very much like wakefulness, except that the brainstem is inhibiting output, and the systems within the brain that clear waste products are very active. Well, the neurochemistry under these systems is quite disparate. So the arousal mechanisms have many different neurochemical underpinnings. Mood is dependent on norepinephrine and serotonin. The one where dopamine is most important is this hallucinatory axis, although antagonizing cholinergic systems can also produce hallucinations. And remember that the major effect of haloperidol is as a dopamine antagonist. Neuronal content is dependent to some extent on the function of cholinergic neurons in the nucleus basalis, but also on the total mass of neurons that are available. Now, these systems are not straightforward. For example, when histamine is invoked as a way of causing wakefulness, you might all remember we used to use antihistamines to make people sleepy. You can see all the different neurochemicals that get involved in this effect of promoting wakefulness, whereas the GABA system is really pretty simple by comparison. I don't want to forget that sepsis also causes microvascular problems, both in terms of changing vascular caliber and also resulting in microthrombi, because focal ischemia due to microthrombi is probably quite important in the brain in the response to sepsis. Well, what can we say about the brain that we can start acting on today? I think most people here will be familiar with the fluid and catheter treatment trial study. And the conclusion that comes from that is that there's no significant difference in mortality, but people who were in the conservative arm spent less time on the ventilator and less time having other organ failures as well. So this table from that suggests that if you're in the conservative fluid arm compared to the liberal, you had half a day extra in the first week and a day and a half extra in the first month, being free of central nervous system failure, which is what was summarized for brain function there. And since that went along with everything else that looked like it was good about getting into the conservative strategy, I think I took this as evidence that, yeah, that's what we should do. But we have to remember how evidence is collected. This is my only publication in the British Medical Journal. Notice class 0 are the things I believe, and class 0A the things I believe despite the available data, which I will hang on to more strongly than anything else. Then are the randomized trials that came to the correct conclusion, and therefore I know their methodology was correct. Then there's other prospective data and expert opinion, but importantly, class 4, randomized trials that came to the wrong conclusion, and therefore I know their methodology was wrong. And then there's what you believe that I don't. All right. So as Henry Mazur once said to me, in 20 years, no one will remember anything else you wrote except this. Well, Mark Mickelson, who's one of our conference chairs, did a follow-up study. This is a subset of people who were available for neuropsychological testing and looked at their cognitive outcomes in quite a bit of detail. And what you see if you look in this paper is that if you look for evidence of people who didn't have cognitive impairment compared to those who did, the conservative fluid management strategy was associated quite significantly with greater cognitive impairment at a year's follow-up. Not surprisingly, patients who were more hypoxic during the study also had more cognitive dysfunction. But you can see this is a 1.56 odds ratio, and this is over 4. So this was a much more substantial effect than the hypoxemia variable. If you look at the individual tests that went into this, memory didn't seem to be particularly affected, nor verbal fluency, not significantly, but executive functions and overall neurocognitive impairment were quite impaired in the conservative fluid arm compared to the liberal fluid arm. So the next time you start thinking, well, I'm going to really use this conservative fluid strategy to try to get the patient off the ventilator faster, you might want to think twice. Now, admittedly, this is a subset analysis. It needs to be studied in a much larger group prospectively, but it should give us some pause to think that the things that we do in terms of trying to get people off the ventilator a little faster may not be best for them in the long run. Well, what goes on in the brain that can cause these particular problems that we might diagnose macroscopically? And at least when I was in training, there were a couple of dictums. One was that septic patients are too sick to go to the CT scanner. Well, if you saw the people I send to the CT scanner or the MR out of the neuro unit, you wouldn't think that anymore, right? There's almost nobody you can't scan. And you can always do EEGs. There are going to be other systems coming out to help us measure brain function better. But in terms of looking for structural abnormalities, this is, of course, an autopsy series. There are a number of structural abnormalities. In fact, the vast majority of patients have something that you can find, either a discrete hemorrhage like this, or merantic endocarditis, vasculitis. We have areas of rarefaction, things that look vaguely like central pontine myelolysis, even though there was no problem with electrolyte function. And if you do MRs, you see a wide variety of things like this: widespread white matter dysfunction, perhaps related to hypoxemia or hypotension. A lot needs to be done to understand this in more detail. It's not just in adults. It's been reported recently in our journal in children, actually in the Pediatric Critical Care Medicine Journal. David Menon at Cambridge and his group have summarized the number of things that they have found looking at these patients. And again, the majority of them will have some of these abnormalities found when you investigate them. We can look by EEG. We know, for example, that patients who have sepsis have about the highest rate of EEG abnormalities in the medical intensive care population. Either electrographic seizures or periodic discharges were seen in about a third of the patients with sepsis compared to 9% without. And we've seen, when you say periodic discharges, that would show up in Brian Young's study as having suppressions within them. So you saw the mortality there was much higher than we expected. Sepsis survivors, without reference to what the fluid management was, have a lot of cognitive impairment. You can measure hippocampal atrophy if you do MR later on in their course, and their EEGs remain abnormal for a long time. The last thing I want to concentrate on is this paper that's about to appear in the American Journal of Respiratory and Critical Care Medicine from a group that's being led by Ben Singer, who's an outstanding young scientist and clinician. And in both animal models and in autopsy brains of patients, it's become clear now that the brain is not immune to the spread of bacteria through the nervous system. I'm not going to have time to go over this in great detail because it's a very complicated paper. It will be out shortly. I was lucky enough to get a preprint to use here. You can get a typescript off of the Blue Journal website. So I think what's important to recognize here is that first in the cecal ligation and puncture model in mice and also in rats, looking 5 days after the insult in the ones who had survived, there were still viable gut-associated bacteria in their brains. By 14 days, they had been cleared. The bacteria that are involved are ones that are well known to produce neuroinflammation and are also ones that are common in sepsis. We'll look at that in just a second. So when you look at the brains of humans, now these people survived a lot longer, so these are using molecular diagnostic techniques rather than culture, but it also shows that sepsis was associated with the presence of bacterial DNA or other bacterial markers in brains at the time of autopsy. In their control population that was not septic, none of them had them. The septic patients had long-standing expression of some inflammatory mediators. So their conclusions, I think, are quite important. Bacterial translocation produces neuroinflammation, and that neuroinflammation persists even after the bacteria have finally been cleared from the brain. So this, for example, is in the cecal ligation and puncture. So animals that were just assayed to see whether they had any bacteria in their brain had none. Those who just had antibiotics without sepsis had none. Those who got antibiotics and a sham cecal ligation and puncture, meaning the belly was open but they didn't actually have the procedure done, had none. But those who were septic, even though they were given antibiotics, had a lot of Enterococcus fecalis isolated from the brain on day 5. And of course, as I mentioned before, that clears out later. But while it has happened, it is setting up tremendous inflammation in the brain itself. This is looking at the autopsy specimens. The data are smaller and not quite so clear, but this is something that we need to pay attention to. And in particular, the Enterobacteriaceae are more commonly seen, again, not the bacteria themselves, but their byproducts detected immunologically. So Tarek Sharshar, who did that initial study looking at the MR and autopsy specimens of the septic patients, wrote an editorial for Singer's paper pointing out that brain infection should be more systemically sought via imaging and CSF analysis in the case of altered mental status in patients with sepsis. And in conclusion to his editorial, this raises challenging issues about the mechanism and consequences of bacterial dissemination into the brain during sepsis, emphasizing the necessity to rule out brain infection, and perhaps calling for a reconsideration of the duration of antibiotic therapy in septic patients who develop brain dysfunction. And finally, there's a semantic issue. Should we stop saying sepsis-associated encephalopathy and call it sepsis-associated encephalitis? So I think that gives us all a lot of things to think about and a lot of studies that ought to be done both to confirm this and to figure out what to do about it. But I think it's no longer acceptable to say that the patient's encephalopathic just because they're sick. There's something going on in the brain that's causing it, and it's not only what the systemic organs are doing that might cause brain dysfunction. There may in fact be a substantial amount of brain infection going on that we need to deal with. And it certainly raises the question of when we tend to use broad-spectrum antibiotic therapy, whether that therapy that was commonly used, for example, piperacillin tazobactam, which has no demonstrable brain effect, perhaps should be substituted for by something else. Now, having said that, I'm sure everyone in the room is aware of the fact that cefepime can cause its own encephalopathy. It's perhaps good evidence that it does get into the brain, but we need to do a lot of work to figure out where we're going with this. So I have a few minutes remaining. I want to mention some of the people, in addition to Roger, who've been important in getting me to this point. And for those of you interested in mentorship, this is a nice article that's just worth taking a look at. It's a short read, but Barbara Gastel talks about what her mentors meant to her and how, as a mentor now herself, she is trying to follow in their footsteps. So John Hubbard was a physiologist at Northwestern when I was an undergrad who first got me interested in this area at all. I was headed toward a non-science career until I took this course out of interest, and after about 5 days, I realized that physiology should be my life. Stuart Levin taught me about infections and also just about how to be a doctor. Harold Klowans taught me how to be a neurologist. Frank Morell taught me how to think about research. John Disterhoff taught me how to do cellular research, not that I do it anymore, but what I learned in that laboratory has carried me through understanding a lot of literature I never would have been able to manage. And I think when you're trainees, they might want to spend some time in a lab. Don't just discourage it because it's not going to generate RVUs. Roger, I've already told you about, and Fred Wooten, who was my neurology chair at Virginia, really gave me the chance to take the concept of neurocritical care and run with it. These are some of the many colleagues who have helped me out in the work that I've done and in our clinical work through the years. They're just a fantastic bunch of people, and I'm very proud to be associated with them. These are the fellows I've been lucky enough to train and who I hope are listening when I say that they should be carrying on both investigation and clinical work. And finally, I want to thank my family. We were lucky enough to spend several days vacationing before I came to the meeting here. And without a doubt, these are the people that make my life worthwhile. And I thank you very much.